like to welcome Adam Meehan from Smith and Downey. Adam, go ahead and tell us what you know.
Perfect. So Nicole, thank you very much for having us and for everybody on the line. I'm Adam Meehan. I'm a partner at Smith and Downey. Smith and Downey is a unique little creature in the HR space. We have about 19 employee benefits lawyers, and so we have a very big employee benefits group, which probably makes us one of the largest groups in the country. And each one of us tends to kind of drill down into a certain specialty, whether it's health and welfare or whether it's retirement or whether it's executive compensation. And we have these kind of unique depths of expertise of a bunch of my colleagues. One of my colleagues on the line, I'll be introducing her in a second, that's in our benefits group. And then also with our benefits practice, we have a labor and employment group that does all the traditional and typical HR items on the legal side. And what I like to say is that we'll be talking about benefits over the first half hour, and then Doug Damaris, who I'm going to introduce in a second, is going to be talking about labor and employment during the second half hour. And Doug always likes to have the benefits people go first because, of course, we will put you all to sleep, and then Doug will talk about all the juicy things in HR. He likes to brag that he talks about the sex, drugs, and rock and roll with HR side, while Marianne and myself tend to talk about the benefits provisions and tax code and ERISA and all these other things that basically when I'm explaining to people what I do, my wife tends to kick me and tell me to talk about something else. So with that as the opening, of course, these rules are very, very, very important. They're very technical, so we'll try to make them as fun as possible while going through them. But we'll be sure to cover all the kind of late-breaking CARES Act things. Marianne Dubbs is the partner. Marianne tends to focus more on the health and welfare side of the benefits practice. She does intertwine a little bit with our retirement practice as well, but she'll be assisting me on some of these slides on the benefits side. Doug Damaris is, again, the partner on the labor and employment side and leads our group over there. And Doug will be starting about halfway through. And again, I just think it's such a critical time for employers to listen to what Doug has to say, all this late break-in, fast-flying evolution of the laws. I've been very fortunate to be a witness of Doug out of many of these webinars, and it's such a joy to listen to him because he kind of breaks down all this fast-flying stuff in such a practical manner. So again, Nicole, thanks for letting us present. I think it's a tremendous thing what you're doing for all your clients, bringing together all these resources and potential answers for clients. So I think I'm sure all of your clients very much enjoy it. So turning to our presentation, we'll go ahead and get started. Obviously, a general disclaimer that we try to stay away from legal advice on any particular specific situation. So try to take these as general issue spotting, and then, of course, apply it to your own facts and call specialists like us at Smith & Downey or call Nicole to see if you can get situated in the right direction if you have any very specific and nuanced facts. So to tell a little bit of a story over the past now month and a half, we've been obviously under this COVID-19 thing. It really seemed to really start sprouting off at about a week into March, where all of a sudden everybody, I think the NBA canceled one of its playoff games. The next day, the NCAA March Madness was canceled, and kind of we were off and running from a try to recovery standpoint, and the federal government got to work as well. I believe it was about a week later, the federal government passed the Family First FFCRA legislation that mostly impacted Doug's side of the world on the labor and employment. There was a mandate in that legislation that required all group health plans to provide first dollar coverage with no cost sharing to under their health plans. And that was and this was for COVID-19 testing. I left that slide out of the presentation just because it was an initial statute. A week later, there was the CARES Act. It was, I believe, signed into law on March 26th. The CARES Act had numerous more benefit provisions, and it also had some technical updates to that FFCRA first crack at the legislation. So the benefits part is mostly going to focus on the CARES Act, whereas I think Doug will be a lot on Family First and then other things within the CARES Act. But what we're going to do is we're going to walk through the technical sections of the CARES Act very quickly, and we'll talk about some of the FAQs that have come out since and some questions that us at Smith & Downey have been getting. and then we're going to move into more practical considerations. After that, we'll move into the retirement sector. So here is the 3201 of the CARES Act. It was a mandate that clarified that the test shall be covered, first dollar coverage for COVID-19 testing. What the CARES Act did was it also expanded to include tests outside of the FDA approval process. Certain testing that was being approved by the states was going to fall under that mandate. And I think Mary Ann's going to talk about the FAQs in a few minutes that provided a little bit more guidance on what is included there. The other two features were the first one was obviously everybody is concerned with the price gouging that can occur in an epidemic. And so basically what it indicated was that the COVID-19 testing needed to be covered at the rate specified immediately before the pandemic, or if there was no contract, a cash price posted to the provider's website. And again, the FAQs are going to touch on that a little bit more. And we've also been fielding a lot of questions about how to handle out-of-network providers and things like that, and we'll get to that in just a second. The third section here was the vaccine will be covered at no-cost preventive care. As some of you might know, the no-cost preventive care is an ACA mandate, and it basically indicates that if it's preventive care, that it must be provided for the no cost. And generally, when you get that rating designation as preventive care, you would have to cover that on the first day of the next plan year. This one is a very accelerated indicator. If the vaccine becomes a no-cost preventive care, as soon as it receives that designation, then all group health plans will be required to cover it within 15 days. So it's going to be very accelerated. And of course, for self-funded health plans that obviously bear the cost of this, they need to be thinking about the fact that if the vaccine is expensive, of course, the plan will have to cover that very quickly, and it could impact costs. So that's something to keep on the horizon. The vaccine is expected sometime in 2021, but obviously we all hope that it will be much sooner. Mary Ann, why don't you go ahead and cover this slide for us?
Certainly. Earlier this year, insurance companies began responding to COVID-19 concerns in numerous ways, including offering telemedicine at no cost under insured plans. That created a potential conflict for employers with health savings accounts who are required to maintain a high deductible health plan. In early March, the IRS gave employers the green light to pay for COVID-19 services before the high deductible was reached. In the CARES Act, Congress established a safe harbor for providing telemedicine and other remote care services without a deductible without destroying HSA eligibility. The relief is not limited to COVID medical concerns. The relief is available for plan years beginning on or before December 31st, 2021. So for calendar year plans, the relief will end at the end of 2021. The CARES Act also provided that general purpose healthcare spending accounts, health savings accounts, health reimbursement accounts, and Archer MSAs can reimburse any over-the-counter drug without a prescription, as well as menstrual products. This provision applies to expenses incurred by a participant after December 31st, 2019. Vitamins and supplements will continue to require a prescription. Because covering over-the-counter drugs is optional, plans that want to adopt this provision should be amended. On the next slide, we'll talk about a moratorium on the requirement that participants be notified of such amendments. Groups that distribute lists of permissible expenses will no doubt be promulgating new lists. However, note that it will likely take some time for retailers to reprogram their systems to permit debit cards to be used for those expenses.
Perfect. Thanks, Mary Ann. And I'll note here that it was interesting in the legislation, this over-the-counter products provision, it looked at first like they were just trying to define the menstrual care or the menstrual product as health care for purposes of reimbursement. And that's actually was my one takeaway. And in doing so, they actually deleted that 106F section. And I could have swore at the beginning that I thought that might have been unintentional. And for everybody on the call, when they deleted the 106F from the Internal Revenue Code, that was a provision that actually came about with the Affordable Care Act that made it a requirement to get a prescription for all over-the-counter drugs except for insulin. So it was such a dramatic change, but it was actually quite subtle in the legislation at first, so much so that a lot of people missed it on the first go around. But it is a very significant change for plans in terms of what they can reimburse, and it's quite the expansion. So that was a pretty notable part of the legislation, and I still wonder whether Congress did it intentionally. It could be the cynic in me. I tend to criticize Congress a lot. I will, while I'm criticizing Congress, take a little moment to say that I did say, and that Doug can attest to it, that our Congress, I think, did a good job generally getting these legislation and the relief out quickly. And obviously, there's more relief that came yesterday for small businesses. So I can only criticize them so much. They have helped in a lot of ways with getting that legislation out. Mary Ann, do you want to talk about the FAQs?
Sure. DOL, HHS, and Treasury jointly issued a frequently asked questions document regarding implementing the various acts passed by Congress. That guidance clarifies that the mandates included in those acts apply to both self-funded and insured plans and provides detailed clarification as to what tests and services are included. Short-term limited duration insurance or programs such as employee assistance programs and on-site medical clinics that provide accepted benefits are not included. States may impose additional COVID-19 requirements in addition to those required under federal law. That would obviously only impact insured coverage. Accepted benefit employee assistance programs won't lose their status as long as the national emergency lasts, merely because they provide benefits related to COVID-19 diagnosis and testing. None of these agencies will enforce notification failures, including summary and material modification requirements, and any requirements to distribute a revised schedule of benefits and coverage. If the notification hasn't been provided, would provide greater COVID-19 coverage. That said, of course, distributing an SMM is a great way to notify employees of any change in a format they are used to seeing.
Perfect. Thank you, Mary Ann. And so one of the things that, as we skip over here to the next slide, we did was we pulled some. I know this wasn't extremely at the beginning interactive, but we pulled some questions that we were receiving from some of our clients, and I thought we'd spend a quick second kind of going through those. And I'll go ahead and handle the first one in the sub bullet, and then I'll ask Mary Ann to chime in on the second and third bullets. But one of the questions we were getting were out of network providers, and the FAQs that Mary Ann just went over really made clear. That was something that the FAQs came out on April 11th, so we had about 16 days between the law being signed and the FAQs, and that was a lot of questions on whether the out-of-network providers had to be covered, and the answer is surely yes for the testing. And then another spinoff was whether they were required to pay the full amount of charges. And even if the plan disagreed with the charges and again, remember, we're just covering testing now. We're not necessarily covering treatment. And the answer is that they, of course, probably would be required to cover it. If you remember, the price gouging part was you'll either have to pay the amount that was the contracted rate that was immediately in effect before the epidemic or the pandemic, or if it was disclosed on a public interest internet website, then they could charge that price. The legislator and regulators thought that disclosing that would keep prices within control, and the FAQs kind of just reinforced that and talked about what it would require to be publicized and make sure that there's no price gouging. Mary Ann, do you have can you answer the second one, where do the new rules apply to a provider visit or telehealth consultation if no test is ordered or administered, but the COVID-19 is simply discussed?
I believe it does, but I'm not sure.
Yeah, that is understandable, and I guess explain that.
It's not a question that I've had yet.
Yeah. So are you thinking about? I mean, when we were thinking about it, I think the question, your answer is spot on. But I think the idea is that the legislation really does go towards testing. So if basically the COVID-19 is discussed, but no test is administered, then I think the legislation would support that it shouldn't have to be covered. On the other hand, when you go through a visit that leads to a test, even if it's a telehealth provider, if you're on the telehealth and it leads, obviously in a telehealth normal format, you obviously wouldn't be able to administer a test. But if the telehealth leads to the ordering of a test, I think that would have to be covered. And then lastly, are all plans required to provide coverage for telehealth visits that could lead to an order? And I think again the answer is yes, combining with the with the last answer. All right. Yep.
Can I ask a
Is that
couple
Nicole?
Yes, I have a couple of real quick questions on the material we've covered thus far. The preventive services under the HSA guidelines, I think you ended up saying that they were gonna make that a preventive service. I just want to go back through these notes, but I circled it as a question. So is treatment or testing or both going to be falling under that first dollar benefit and approved under the HSA for first dollar benefit before the deductible? Is it both? Or
yeah. If we're talking about the preventive care for purposes of the ACA mandate, we're going to be talking about just the vaccine. Okay, so the vaccine is what they're basically doing is they're in preparation for the vaccine to be developed, and they're basically forewarning plans that you're going to have to cover that as preventive care. So that's just with respect to the vaccine. With respect to the HSA, the initial guidance on the HSA from the IRS and related to telehealth, that's just the telehealth ended up being all things, not just COVID-19 testing, but because everybody was indoors, you won't ruin your HSA eligibility if you provide telehealth services across the board, and that's only till 2021. The third thing that I think I heard in your question was this other part of the mandate, that the mandate strictly applies to testing. It doesn't apply to any treatment. It simply provides that you have to cover first dollar coverage under your health plan with respect to any COVID-19 testing. Now, there's questions about whether future legislation is going to require mandates applicable to obviously treatment. That one can speculate that could be the future of the next piece of legislation in Phase 4. But as of now, it's only required to cover first dollar coverage for the testing.
Great. And then I know that there's been some talk about a bill on the prevention of balanced billing. Are we anywhere near that? And if we are or aren't, would you as a legal professional say that there is a good legal leg to stand on to argue in a court with the costs that they're being balance billed for given the circumstances? Or do you say that's a lost cause?
Well, as it relates to testing, I think it's probably a lost cause because I think the idea is that because the plan is required to cover the cost of testing at this time, that there wouldn't necessarily be a way to not pay it, even if the costs were unreasonable, so long as it's a contracted rate or it's posted somewhere on an internet website. So if those two things happen, I don't think there's going to be much of that happening, much of it going on, because the plan will have to cover all the costs. If they don't post the price on a website, theoretically, that could be happening. The provider could charge the plan. The plan can refuse to pay it because it doesn't fall within those two mandates. And then, of course, the provider can go after the participant for any excess cost.
What about in the treatment side of this? Any arguments that can be had there? So if there's a balanced bill as it relates to the treatment, because if we're assuming that they're going to an in-network hospital because they're in an area where they have quick access to that, and that hospital is not going to be overwhelmed and go anywhere else, right?
Yep.
So if they get sent out of network under no choice of their own, I don't believe these professionals are looking through and looking for the best pricing for where they're going to send these patients if they're sending them somewhere. So I guess what I'm asking is, do we have any legal legs to stand on as it relates to going after them, and even if it's for the balance billing on the treatment because we were out of network. Is there anything that we think we see coming or that we could prepare for in that respect?
I would say probably let's hope there's, I think the next wave of legislation will probably give us some more guidance on the treatment.
Okay.
But I think the idea would be is that we would probably look at reasonableness and any kind of contracts that we can get our hands on to try to figure out whether we have a leg to stand on. But it would probably be just like everything else, right? Any approach that we had taken pre-COVID would apply to COVID treatment. And I'm sure that's going to develop, here shortly. We just haven't had any kind of opportunities to really evaluate that yet. But I think that's some great foresight into actually what's probably going to come next.
Yeah, I was just kind of hoping there would be some, there's advocacy groups and we work with like reference-based pricing where we obviously are able to try to beat them up a little bit on and get them down maybe a little closer to what Medicare reimbursements look like. And that's kind of what I was aiming at is there any way to use that Medicare pricing guide and say, come on, we're way out of range here, or, we're being gouged here from that perspective?
Yeah, I think it's probably more of a spirit, when you're looking at the spirit of the legislation to this point. And, what surely will be developed. If it happened today, I think we would just go to the spirit. I'm hoping in 2 to 3 weeks, we would have a little bit more firm guidance to hold that pricing down. But, the answer really is, if it occurs, we're looking for the best possible angles, but I don't think we have any leg to stand on at this point in terms of definitive arguments.
Okay.
So, quickly turning to the next slide. This is again an issue spotting thing because we're going to get to the retirement, and then I'm going to, as I mentioned, turn it over to Doug. But clearly, bullet number 1 is the most important. Furlough is kind of like the word of the year. Every year, you get some new word that you hear more than you've ever heard before. And obviously, I've heard the term furlough before, but over the past month, I've heard it so many more times than I ever did before in my career. And we've been constantly getting calls trying to balance the furloughs with the measurement periods. Marianne, do you have any quick thoughts to do some forewarning against potential issues in this space?
Yeah, it definitely has come up a lot because many employers' initial instinct was to offer to continue coverage, especially medical coverage, to workers who have been furloughed or laid off. And in the beginning, I think everybody was sort of treating those two the same. The first consideration is always, of course, whether the insurer or stop-loss carrier will agree with whatever the employer wants to do. And that has certainly brought some people, to a screeching halt. Somewhat to my surprise, I confess, in many cases, the initial answer has been favorable, although most insurers and stop-loss carriers are quick to add that such provisions can't be for an indefinite period of time. There is another important issue with respect to furloughed employees specifically, because such employees are still employed. Therefore, if the plan uses the look-back rules to determine eligibility, some of those individuals will be in a stability period, and the plan must continue to offer coverage to them because they are still employed, even if the insurer or stop-loss carrier is not amenable to that. That same issue does not arise if the employees are laid off and are no longer employed. Of course, to the extent the continuation of coverage conflicts with the plan document and summary plan description, they should be amended and employees notified, although, as we mentioned earlier, the Department of Labor has announced it will not enforce that notification requirement.
Perfect. Thank you, Marianne. And I'm going to pick out actually, before I move on, let me just double stamp what Marianne said. This is by far the most important issue. Anybody who's listening to this, we all have to understand that we're in a little bit of a feel-good period right now where we're all rowing in the same direction and we're kind of pulling together. It's really trying to fast forward 6 months and think about the ways that really plaintiff lawyers think. And what we need to envision is that there could be scenarios where we chose to cover people and we forgot to tell whoever is insuring against our risk that we were doing that. So if, God forbid, somebody has brain surgery in 3 months and you're an employer who offered to continue to cover that employee and you're a self-funded plan and you forgot to tell your stop-loss carrier, there's a chance that the stop loss carrier, when they start investigating and realize that that furloughed individual was not actively at work, that they may deny it. Fortunately, I'm sure Nicole's been talking to a lot of carriers and a lot of other folks. Fortunately, the carriers have been pretty readily agreeable to cover people who are furloughed. But if you're an employer, you don't want to just take that general notion. You want to reach out specifically to your carrier and make sure your carrier is specifically agreeing to cover those things, because you don't want to be put in a position where you're covering and you're covering and the carrier is not. A few other small little points on this slide is just thinking about when to start the COBRA period. The COBRA period might start for some of your reduction in hours folks right now, and you could start the COBRA period, the 18-month COBRA period now by giving a COBRA notice. If you don't do it now, you'll have to do it at the end of whatever the furlough period is, if the furlough ends up turning into a termination. Some other things that we're looking at are just a lot of questions on the dependent care FSAs. I will say quite generally, a lot of the COVID-19 impacts of people staying at home have led to qualifying events to change your dependent care FSA elections. On the flip side, a lot of the questions we've received in trying to change health FSA elections haven't really qualified. But of course, it's based on the terms of your own plan document and whatever the terms of your plan document and the particularized facts. Let me turn quickly to the other aspect of our presentation on the retirement side and kind of the other provisions. The two I want to mainly focus on to make sure everybody on the call gets it before we turn it over to Doug are the coronavirus-related distributions and the plan loan features. So there were two big allowances under the CARES Act. The first one allows retirement plan participants to take up distributions up to $100,000 and not be subject to a 10% tax penalty, even if they're under age 59 and a half. What that really does is it allows the individual to avoid the 10% tax. They avoid withholding from that distribution, and the plan sponsor can create a distributable event, an in-service distributable event. There were some cool tax features about this distribution. It allows the participant to take it into income ratably over a 3-year period, and it also lets people repay it to the plan over the next 3 years. If you're a plan sponsor, you should be looking at your record keepers, because your record keepers, some of them automatically implemented this distribution feature unless the plan sponsor told them affirmatively not to. As a plan sponsor, you should make sure you understand what's going on with your plan, and because you're going to have to amend the terms of your plan at some future point to account for the distribution. The other thing it did was it expanded the plan loan limits. The first plan loan limit was the expansion from $50,000 to $100,000, and then 50% of their account to 100% of the account. It also allows for some outstanding or loan relief for outstanding loan payments that are otherwise due in 2020, and they can be delayed for 1 year. There's some technical nuances to working that out in the delay of the payments, and that's something that, of course, again, you want to be looking at your loan policy and working with your record keeper on. The notice 2020-23 extended the due dates for many time-sensitive acts, including most notably the loan repayments. For some of the nonprofits on the phone, they probably noticed that their Form 5500 that might have been due April 15th was extended. All of these items are extended until July 15th, 2020. Again, here's a rundown on bullet points of different things that were extended, mostly minor ancillary issues, but they're all going to be pushed back till July 15th. And so you want to, again, make sure you're working with your record keeper for the loan repayments issue especially. Remember the retirement considerations, the voluntary implementation of the COVID-19 flexibility. You want to know what's permissive and what's mandatory. Generally, the loan repayment relief is mandatory. The other provisions are permissive. Even the RMD waiver, which some of you might have heard about for 2020, that is permissive for purposes of your plan, but there will be some reporting guidelines that you have to switch up with. There's some other rules that you want to make sure you're thinking about in furlough situations. You want to be thinking about the partial terminations rule for your 401k plan. If you have unvested contributions, those could become vested. but it's a facts and circumstances test. So if you're laying off a lot of people and you have a vesting schedule under your 401k plan, you should probably reach out to counsel and think about the most appropriate way to handle that termination.